Again, good morning, everybody. Bonjour à tous. Thank you for coming. It's a very interesting session, couple of very interesting sessions this morning, and we wish that we all learn a little bit and we can take home very interesting messages. So we will start right away with Dr. Michel D'Hooghe. Is one of our FIFA stars today. We have a couple of them in our first session this morning. He is the long-standing chairman of the FIFA Medical Commission. He made a great push to this commission in the last maybe 20 years. And we all know the unbelievable work that the FIFA Medical Commission has done in the last few years. And there is nothing much to say that welcome our friend Michael.
Hello,
good morning.
Good morning. Good morning, everybody. Early morning. Dr. Scott Gilroy, excuse me, Monsieur le Professeur Neret. Dear colleagues, ladies and gentlemen, allow me first of all to thank the organizers of Aspetar for their hospitality and for the high level of this scientific congress. We are, from part of FIFA, my colleague Yassine Zerguini and myself, we are really enchanted to be here and to take part to your discussions. Some of you may think, why such a challenging or even aggressive, or even more pretentious title for a conference about sports medicine? Well, the answer is simple. Since more than 45 years, I served in the sector of sports medicine, more particularly in the locomotoric aspects. And I accompanied and so many times guided the evolution of football medicine. In so many conferences all over the world, also here yesterday, in so many articles, I was confronted with new techniques of anterior cruciate tear repair. I learned so much about concussions, a very actual theme in sports medicine, together with the sudden cardiac arrest. I studied the instability of the ankle. I was instructed, together with many of you, about the proceedings of the doping control, including today the biological passport. Over the last 10 years, FIFA and the world of football did some 300,000 doping controls with less than 0.4% positive results. In Brazil, 2014, we performed some 1,033 doping controls on blood and urine. It was the first time in the history of team sports that all the athletes were controlled. So I nearly forgot that the most important problem concerning the lesions in football is not a bone, not a tendinous, not a ligamentar, and even not an articular lesion, but simply a muscular lesion. And this is illustrated and proven by epidemiological statistics. In our football game, muscle injuries are responsible for more than 30% of all players' injuries and cause about 1/4 of the total time of playing and training incapacity. 90% of all muscle injuries concern 4 muscle groups of course, the lower extremity, as you see there: hamstrings, adductors, quadriceps, gastrocnemius. The hamstring group is reported to be the most common injury, representing more than 1/3 of all muscle strains. 70% have an acute outset, and in 90% the lesion occurs in a non-contact situation. Here I show you some recent examples with some top players in the world. A professional team And here you see the #1 team on the FIFA ranking. With, excuse me, with 25 players, may expect about 5 hamstring injuries each season, equivalent to 80 lost football days and 14 missed matches. You will immediately understand the sportive and financial repercussion and the consequences on the final result. Most hamstring strains in soccer affect the biceps femoris in some 84%, while the membranosus is affected in 11% and the semitendinosus in 5%. Hamstring injuries have also a high recurrence rate, essentially focused on the biceps femoris. And over the last year, this is important, we also find a gradual increase in the proportion of hamstring strains compared to other injury types when compared to data from studies from the 1980s. Thus, is it then so strange that I call the hamstring injury the #1 lesion in football? Let us first freshen up a little bit our anatomical knowledge. Here you see the different muscles of the posterior side of the thigh. I think this needs no further comment. Some of you, and certainly the French-speaking people, may have heard of the famous French book, The Three Musketeers, Les Trois Mousquetaires, written in 1844 by Alexandre Dumas. It tells a story of the 17th century around the French king Louis XIII, Louis XIII, and the famous Cardinal Richelieu. Well, in fact, my dear colleagues, the Three Musketeers were 4 persons: D'Artagnan, Aramis, Athos, and Porthos, responsible guardians of the protection of the king. Well, I always compare the hamstrings with the Three Musketeers. They protect the stability, not of the king, but of the lower extremity, so important in football practice. And they consist out of 3 muscles, as you know, the biceps femoris, the semitendinosus, the semimembranosus. But in fact, it concerns a group of 4 muscles, as the biceps femoris has a long head that is biarticular and a short head that is monoarticular. Let me limit the anatomical considerations to the fact that the biarticular muscle straightens the hips and bends the knee, while the monoarticular only bends the knee. The long head of the biceps, the semimembranosus and the semitendinosus, biarticular muscles, find their origin proximally at the ischial tuberosity, pass posterior to the hip and knee joint. They straighten the hip joint and bend the knee. The monoarticular short head of the biceps finds its origin on the femur and crosses the knee joint. So this muscle only bends the knee joint. The distal insertion of the biceps femoris concerns essentially the head of the fibula and the lateral side of the tibial plateau. The distal insertion of the semitendinosus is part of the pes anserinus, inserting into the medial surface of the tibia posterior to the attachment of the 2 other muscles forming the pes anserinus, as you know, the sartorius and the gracilis. The semimembranosus inserts distally on the posterior aspect of the medial tibial condyle, the popliteal fascia, and the oblique popliteal ligament. Until here, some refreshing anatomical considerations. The muscles forming the hamstrings are very specific for their long tendons, what will be, as we will see later, an important factor in the rehabilitation. The origin of the word hamstrings comes from the butchery trade. Slaughtered pigs were hung from these strong and long tendons, hence the reference to ham and string, referring to the string-like appearance of the tendons. We should be aware of an important number of risk factors for hamstring injuries, and more particularly for re-injury. Indeed, a previous hamstring injury is from far the major risk factor for subsequent injury. In general, athletes with a history of hamstring strain are 2 to 7 times more likely to suffer a subsequent similar injury with the highest risk in the first 8 weeks following return to sport. 13% of the players suffering a hamstring lesion can expect a re-injury in the same one season. Increasing age is also commonly felt to be a risk factor, as well as low hamstring muscle strength. Other less important risk factors are the flexibility of hamstrings and quadriceps, the core stability, and the race. Players of black or aboriginal origin sustain more hamstring strains than white players. The question remains if this is due to the fact that they are many times faster runners, or to the fact that they have a higher proportion of type 2 muscle fibers. Like for all muscle injuries, other factors can intervene. The level of play, insufficient warming up, muscle fatigue, and also the position of the player in the team. The hamstrings should not be viewed in isolation of surrounding ipsilateral and even contralateral muscle groups. And as an example, the ratio hamstrings quadriceps may be a predictor for hamstring strains. A previous calf strain can also increase the risk for a hamstring strain. So the entire kinetic chain should be considered in relation with the injury risk. The diagnosis of a hamstring strain is classically based on the 3 classical elements: history, clinical examination, imaging. The history is that of a sudden onset of posterior thigh pain, mostly without any contact, and the absolute inability to continue playing. What can be the causes of pain in the hamstring area? Well, you see there are multiple ones. Lumbar disc prolapse, disc degeneration, spinal stenosis, spondylolysis, listhesis, vertebral fracture, anomalies, other radicular and pseudoradicular pains, neurological diseases, neuritis of the sciatic nerve, neurinoma, tight hamstring anomaly. We must also consider the differentiation between the piriformis syndrome, the post-traumatic one, the hamstring syndrome itself, the avulsion fracture of ischium, the apophysitis of the ischium, the different parts of the muscle tears, the posterior compartment syndrome of the thigh, and the posterior hip rotator injuries. So it's a whole group, as you see. Let's have a look at the piriformis syndrome and its symptoms. We find pain at upper gluteal area with radiation to posterior thigh and down the leg, specific post-exercise and night pain, and a position whereby the leg is held in semi-flexion and in outward rotation in bed, and after sitting a long time, it becomes more and more difficult. The clinical findings of the piriformis syndrome: gluteal pain over the muscle and the nerve, increase of pain at resisted abduction and external rotation, some call that the Pace's sign, forced internal rotation of extended thigh, the Freiberg sign, and a diagnostic test is the local anesthetic injection that is positive. Examinations, of course, the clinical examination remains from far the most important. X-rays, ultrasound, MRI, electromyography can eventually be positive, but in fact there is no specific test or examination to diagnose the piriformis syndrome. And this syndrome, when we speak about it, we must consider different parts. Syndrome by overuse, by nerve anomaly, a post-traumatic one, and finally radicular syndromes. Considering the piriformis syndrome, we must know that in 6.2%, part of the sciatic nerve goes through the piriformis muscle, that it can be hypertrophic or its tendon anteriorly thick, that there can be vascular anomalies, and that usually no abnormality is seen in surgery. Now, the clinical examination shows, of course, tenderness upon palpation and pain at resisted hamstring contraction that you can do on different ways, as you know. It's interesting to note that the closer the palpation pain is to the ischial tuberosity, the longer is the time to recovery to pre-injury activity level. The knee active range of motion loss with patient supine, hip flexion of 90 degrees, and active extension of lower leg until resistance, well, when it is less than 20%, than 20 degrees, difference to the uninjured side, there is a better prognosis and less than 2 weeks injury time loss. On the contrary, if it is more than 30 degrees, then over more than 6 weeks injury time loss must be considered. Persistent strength deficits, as measured by flexion extension force measurement, elevate the risk of re-injury. As in nearly all cases, imaging has a triple function: confirmation of the clinical diagnosis, gradation of the injury, and also information about prognosis of return to play. The gold standard was before the echography, but is today certainly the MRI scan. It is generally accepted that MRI scans are superior to ultrasound examination. Important is the prevention of hamstring injuries. Here I can be brief, as the next speaker will describe the predictive factors for hamstring injury. As we have seen when we considered the risk factors, some as age, race, or previous injury are not to be avoided, but others can be trained. The limitation of the range of motion of the hip, the low hamstring strength, resulting in a low hamstring quadriceps ratio. Hamstring strains can very frequently be prevented, essentially by intervention method, targeting the key risk factors, essentially the hamstring strength and the hamstring flexibility. So studies about stretching in professional football teams indicate that correct stretching reduces the injury risk, but the best prevention is proposed by an increase of the hamstring strength, particularly eccentric hamstring strength. More effective, most effective hereby is the famous Nordic hamstring exercise, well known to our Norwegian friend Roald Barr, who is also active here in Aspetar, during a 10-week training program. The subjects are instructed to let themselves fall forward and then resist the fall against the ground as long as possible by using their hamstrings, while their feet are kept on the ground by a partner. And studies showed that this led to a decrease of 71% of all hamstring lesions and even a reduction of 86% of re-injuries. But take care. When you start training this, take care for your nose, because when you fall down, you could have your nose broken. The 11+, they spoke already about it yesterday, the famous prevention program of FIFA and FMARC, directed essentially towards non-contact injuries, contained a lot of exercises preventing hamstring strains. And in some statistics, thanks to 11+, we see a decrease of up to 50% of non-contact lesions. Let's speak about the treatment. In the treatment of hamstring injuries, 4 aspects should be considered: the medical management, the surgical management, the hamstring rehabilitation, and then, of course, the return to play. The medical management is this one limited to the diagnosis and the decision of return to play, or are there methods available that may enhance recovery? Ideally, the medical intervention towards repair of a muscle injury should be directed towards minimizing degeneration, optimizing inflammation, maximizing regeneration, and of course, avoiding as much as possible fibrosis. Which methods are herefore available, and what are the limitations of these methods? Well, let me first say that there remain a lot of doubts about the following medications that you can read there. A hematoma aspiration can be a available tool in exceptional circumstances rather than in common practice, because it is not uncommon for a hematoma to reform following aspiration. And one can wonder what impact this has on the local healing process. The non-steroidal anti-inflammatory drugs have often been a popular choice in the management of hamstring injuries. However, animal models have often shown suboptimal myofiber regeneration and increased scar tissue deposition. Dear friends, you must note that NSAIDs are of very common use in football players. Statistics at the last World Cups show that in some groups of 23 players, simply all take these medications, and some of them take 3 different ones. I am very much concerned, much more than in the use of doping, I am very much concerned by the fact that we see this more and more in the youth categories. It is difficult to justify any role for NSAIDs, particularly given the large number of potential systemic side effects, essentially on the gastrointestinal and urogenital, but even also on the cardiorespiratory system. Intramuscular cortisone, it was already said here yesterday, have in fact a negative impact on muscle regeneration. So we do certainly not support the use of corticosteroids in muscle injuries. There is also no substantial base to advise infiltrations with the homeopathic product Tromil, popular in some regions. To maximize the muscle regeneration, in some places of sports medical practice, actovegin is injected. This is a deproteinated calf blood hemodiacylate that is believed to enhance muscle regeneration. Recent studies with a limited number of subjects support a benefit of actovegin injections. For the moment, we consider it is still in an experimental phase, although it became already a routine treatment in some professional clubs, like in Bayern München. Another method to try to maximize the muscle regeneration is with the platelet-rich plasma, the PRP. The technique of deriving plasma concentrated in both platelets and growth factors is today widely used in some fields of medicine, with some promising results sometimes. However, the use remains an area of research where we strongly hope to obtain a definite scientific support shortly. Hyperbaric oxygen therapy also remains extremely controversial in the treatment of hamstrings. Important is that we try to minimize the scar tissue formation, being it with growth factor TGF-beta or with losartan, an angiotensin II inhibitor, blocking the action of collagen deposition. Indeed, and consequently, reducing fibrosis in the replacement of muscle tissue with fibrotic collagenous scar will reduce the strength of the muscle and increase the likelihood of re-injury. After clinical studies on animals with many products, relaxin, interferon gamma, decorin, suramin, it seems today that losartan, an angiotensin II inhibitor, commonly used for its antihypertensive properties, is the most promising medication. but there also it remains a challenge and further study is necessary. Well, the conclusion of all that is that over the last 30 years, not much progress has been made in the medical management of hamstring injuries, that many treatments lead to doubtful results, but that we must keep an open mind for the research that is actually being done. The surgical management concerns essentially the proximal hamstring rupture. Proximal hamstring ruptures are less common, but may still account for up to 12% of hamstring complex injuries. Surgery was classically advocated for 2 tendon avulsions with more than 2 centimeters of retraction and for 3 tendon tears. I mentioned an interesting recent publication concerning successful hamstring injuries by the successful surgery by our center, our FIFA Medical Center in Lyon, and that concerned 10 athletes who were not receptive for conservative treatment. When there is an indication for surgery, it's important to know that surgery becomes technically more difficult with time due to tendon retraction and sciatic nerve tethering within scan tissue. Do not forget that the post-operative rehabilitation after surgery is long, and that it can take up to 5 to 6 months before one has achieved greater than 80% of the contralateral strength and patient can return to sports, including sprinting. Let us come now to the third and most important part of this conference, the classical hamstring rehabilitation, whereby an excellent schema has been prepared by the collaborators of Aspetar, being it Mr. Witfrau and Mr. Rottweidli. Good rehabilitation after an injury is not only important for a fast return to sport, but also most likely for decreasing the chance of re-injury. In order to develop a good rehabilitation program, a complete understanding of the biomechanical function of the hamstrings during sprinting is imperative. The long head of the biceps femoris had the largest increase in length, 12%, while the semimembranosus produced the highest force and absorbed and generated most power. This suggests that the pathomechanics of the different muscles are different, and consequently that the injuries need a different treatment approach. And so the biceps needs emphasis on lengthening, and the semimembranosus needs a strengthening approach. As the majority of hamstring injuries are located at the biceps femoris, most treatments should emphasize the lengthening. This is traditionally performed by the means of a stretching program, but better is to perform repetitive contractions in elongated positions to allow for longer operating lengths. Eccentric muscle training in elongated positions is the best solution because it shifts the optimal length to longer muscle lengths. Additionally, the strengthening of the hamstring muscle is an interesting benefit. Important is to do the eccentric hamstring exercises in elongated position. Also, the pelvic position plays an important role in the total hamstring length, so sufficient neuromuscular control of the lumbopelvic region is needed to create optimal function of the hamstrings during sprinting and other high-speed skilled movements. The last part is the return to play process for hamstring injuries, not the easiest. There are, in fact, no consensus guidelines for safe return to sport activity, and that decision is frequently influenced by clinical findings. Location, size, strength lost and regained, pain-free range of motion, tenderness, and this should be controlled by looking via MRI at the evolution of the lesion. In 2010, a useful 3-step based model was proposed helpful for the final decision. Assessment of an athlete's risk of return to sport based on the health status and the specific risk for injury or re-injury. So high-risk sports like water skiing and football lend themselves to a delayed return to play, considering the high incidence of re-injury. The position or role in the sport is important, as is the fact that a lesion on the non-dominant leg can lead to a quicker return to play. It's evident that the demands on elite level are greater than in recreational sport. Step 3 involves what we call the decision modifiers, factors that may change the decision that would have been made had risk evaluation been the only consideration. This can include social, economic, psychological, and legal issues. So finally, the take-home message. The frequency of hamstring lesions, the high percentage of re-injury, 3 muscles, remember the musketeers, are 4 muscles, knowledge of risk factors, diagnosis by clinical examination and imaging, prevention, never forget the Nordic hamstring, certainly never forget 11+, the limits of medical and surgical treatment, the absolute importance of a correct rehabilitation, and the different return to play criteria. My dear colleagues, in your treatment, in our treatment of some 300 million young football players all over the world, never forget what our prestigious colleague and master, Harvey Cushing, said one day. If a medical life is not a divine vocation, nothing is vocation and nothing is divine. Working in the field of sports medicine, believe me, is a vocation. Helping young athletes to fulfill their sportive ambitions is simply divine. I wish you all to work with that divine vocation. Thank you very much.